Hello again, everyone, and welcome to today's episode of Resilient Health Radio. I'm your host, Dr. Darren Ingels, and my guest on the podcast today is friend and colleague, Dr. Chris Winfrey. Dr. Winfrey is a board certified psychiatrist and has a practice in Marlton, New Jersey. And he's also an expert in Lyme disease and PANS and mold illness and a lot of these complex illnesses that a lot of us now are treating these days. But, he's got this really unique perspective on certainly the neuropsychiatric aspect of Lyme and other tick-borne illnesses. So, Dr. Winfrey, welcome to the podcast.
Thank you. Thank you for having me.
So, let's dive right in. I think when we think about Lyme disease, people think about the classic symptoms: joint pain, headaches, fatigue, neuropathy. And I think, the neuropsychiatric aspect of these illnesses can really get overshadowed and often overlooked. What's your experience been in your practice, with these kind of symptoms when people are coming to see you?
I think for people to come to see me, um, they oftentimes are coming in presenting with these symptoms. They very well may have joint pains and things of that nature, but because I am operating in the realm of neuropsychiatry, they are presenting more with me with these symptoms. This is they present. Now, some come in and they may just endorse symptoms such as anxiety or depression or trauma or confusion. I would say those or symptoms where what they may call ADHD. Um, I would say kind of maybe the five clusters that are the most common. What I have grown to appreciate is that there are some other symptoms that I think oftentimes are not fully appreciated, I think are um, perhaps really important. So, for example, discrimination in the cognitive realm, discrimination is a really important symptom that I think comes up quite a bit. Orientation, I think, is another symptom that comes up quite a bit. There are clocks in the brain and the body, the master clock regulating the circadian rhythms and things, but there are other clocks. Perceptions of time, I think, are other sort of symptoms that I see in that sort of cognitive realm that is really important. Um, I think dissociation is a common one that people may have heard of, but I think there are different types of dissociation um, that I would kind of say is in the cognitive realm. In the psychological realm, I think I've oftentimes hear people say that you can have these sort of issues and be asymptomatic. I think if you're thinking about this from joint pains or muscle pains or something like that, you might think that. But when you include the neuropsychiatric symptoms, I find it hard to believe that anybody can be asymptomatic. I think we can find any of these sort of symptoms emerging. I have people all the time that have they bring the kid in that has PANS or PANDAS and has like Bartonella or something like that. And I'm listening to the parents. I can hear these Bartonella symptoms in them, but they're telling me, "Hey, I'm fine. I'm fine. I don't have any problem. It's just my child." And I think sometimes these sort of things are overlooked. Um, in existential sort of symptoms, I think is another group as well, where we have issues of meaning and identity and belonging and connection. And how do we go about um, finding meaning in life? How do we go about reascribing or reevaluating meaning? How about narrative formation and being able to assume the position of, um, an active role in my narrative in my life, where some people are kind of more passive or don't really feel engaged. These are all sort of symptom clusters that I think are important, and some of the latter ones that I just mentioned, I think are oftentimes overlooked and are really critical for some people and us. I think the such as the existential symptoms um, become some of the gateway to the spiritual symptoms that I think are really important. That oftentimes overlooked issues of faith and trust um, that I think are really critical for the success of the treatment. That I think show up quite a bit as well.
Yeah, what is the mechanism? I mean, what do you think's going on that is really triggering, this sort of broad collection of neuropsychiatric symptoms? Is it the organism? Does it literally invade the brain? Is it autoimmune? Is it a little bit of both? What are your thoughts on that?
Yeah, it's a really good question. So I think the field of psychiatry has been co-opted in the early 20th century by the drug industries, pharmaceuticals. Um, and so some of the early drugs that we had were like lithium came out in 1938 and thorazine came out in 1954. Then we had the MAO antidepressants, and then gave rise to the first SSRI, I think in 1980 or so, or maybe it was 88 with Prozac. And they thought they had psychiatrists and psychologists on their team, predominantly led by psychiatrists, and they thought, hey, we could really sell this neurotransmitter model. And it's a very simple model. People can simply understand it. We can just talk about how your brain is off because you don't have enough serotonin. And if we give you this drug, it lifts your serotonin, you feel better. And it was a great marketing scheme to make money, in which they made lots of money. And I think that sort of thought process has pervaded um, into society, and it's how most people are thinking, hey, I just got a chemical imbalance and I can just get my
Right.
chemistry right, I'll be fine. Well, I think the toxins, the infections, traumatic brain injuries, COVID, heavy metals have given us a window that into the complexity of these of the brain that goes beyond just this catecholamine neurotransmitter hypothesis. And what the latest research is showing that we have networks in the brain, and the brain is organized into these sophisticated sort of silos and nodes and networks. So a couple of those networks, the default mode network, the central executive network, the salience network, dorsal and ventral attentional network, the action mode network. So the default mode network is the part of the brain, it's a collection of areas of brain that refers to your inner world. You're thinking about you're thinking about emotions, thinking about your past, what you're going to do in the future. It's self-referential sort of, thoughts. Central executive is kind of outward focused. You kind of organizing and planning. Action mode is being able to be goal directed and putting those things into action. And then like the salience network is trying to toggle between those. And so you can have dysfunction in any one of these networks. And what we see with the infections when they invade, like Borrelia invades, Bartonella doesn't invade the brain as much. It's mostly restricted to the endothelial cells, the red blood cells, but it's toxins and endotoxins that secretes does leach out of the vascular system and invade cells and disrupt mitochondria and things of that nature. And it also injures the brain by disrupting blood flow and blood supply, creating sort of local ischemia and hypoxia. Babesia doesn't quite invade the brain the same way. It's mostly localized to the vascular system inside of red blood cells, but very similar, creating clusters of dysfunctional red blood cells, creating Babesia nests, and then disrupting capillary flow, and thus oxygen deprivation and mitochondrial dysfunction. The parts of the brain that demand the most energy get hit the worst. And so when you're needing to think outwardly and plan, that's your central executive network engaging. And it needs a lot of energy when you're trying to do that. When you're needing to think on the inside and thinking about your inner world and things of that nature, your default mode network requires a lot of energy there. And so what we see is that these networks get disrupted. So it's not only are they disrupting um, the neurotransmitters, but we see that when we add just simply psychotropic medicines and we're trying to modulate the chemical response, we don't always get people recovered just with medications alone. And that is a clue that we have a network issue. And therefore, it requires us to be thinking a little bit differently about how we're going to help people recover from their brain. And I think the disconnect that we're having here is once we're treating mold and we're detoxing the mycotoxins, once we're treating the Lyme and the Bartonella, etc., these networks are still dysfunctional or aberrant afterwards. Because say you have someone who has congenital infections or these congenital issues, that means their neural circuitry has been off maybe since in utero.
Right.
So now they're 35 years old, they're getting treatment, and now they had a nice, successful treatment. But the way they engage in the world is through this neural circuitry that was aligned a certain way at the hands or influence of these infections and toxins. And so now they're going to have a discordant experience with reality that they're going to have to rework. And so they're going to need two additional treatments. One, to help reboot their neural circuitry, and then two, adjustment to reality with a new brain circuitry.
Yeah, I mean, it sounds like, toxicity is still really a big driving force behind a lot of this. Like I said, it's the mycotoxins, it's the toxins secreted by these different infections. And at the end of the day, it's like, how do we get ourselves less toxic? How do we, at the most basic cellular level, get that cell to function the way we want? And of course, I think we'd all agree we live in a more toxic world. It's not getting much
Mhm.
better. I've been in practice for about 26 years, and it is harder and harder to treat complex illness. And I think a big factor is just that people are just exposed to more and more toxins every day. And so we might have identified Lyme disease or Bartonella as potential triggers, but we're dealing with that swath of underlying, gunk, in the rest of the body that we're trying to overcome to help the body naturally deal with these infections on their own.
Yeah, absolutely. Absolutely.
Yeah, I wanted to ask you because I've seen this in a handful of my patients. This you mentioned it a little bit when you talk about some of these like dissociation. I hear the word depersonalization, where people feel like they're having these out of body experiences. Can you share a little bit about what you've seen about that specifically, and what potentially is going on there?
Um, so the part of the brain, the network that I was just referencing, the default mode network, um, is a network that if it is hyperactive, we have people engage in self-referential thoughts, self-criticism, self-judgment. They're just thinking about themselves all the time. You criticize them and they just can't shake it. And they've been thinking about that criticism for 2 weeks. They hadn't let it go. That part of the brain is hyperactive and they can't tone down or shift their thinking away from them into something else or something outside themselves. But if the same area of brain is more hypoactive, then the person is going to not be able to get into their sort of inner experience and inner world very much. They're going to be more disconnected and dissociated from it. And so, um, how this plays out with like Lyme or Bartonella, for example, if you consider how Borrelia disrupts mitochondria in the brain, and this area of the brain requires a lot of energy, then this area of the brain is going to be hit really well. And we can see sort of a couple patterns on PET scan of how Lyme hits the brain, either like a global hyperactivity sometimes, or in these sort of clusters in the temporal lobe. And when these nodes or these networks get hit like that, and we can also see this in Bartonella, um, the person can't quite get into the experience and have an embodied experience. And so they're disconnected. And so if you're trying to get them to be self-aware, if you're going through treatment, for example, as a practitioner, and you're saying, "Hey, I think you're getting a little better," and the person says, I don't think I'm getting better. I don't see an improvement. They can't, that part of their brain is so dysfunctional, they can't quite see themselves very well. They're
Right.
still very disconnected. And that can be kind of frustration not only for them and for others. This is also the part of the brain that not only for them to get into their experience, but for the concept of theory of mind, to be able to understand what's going on in the mind of the other person. And this is what we see. This same particular network is also involved in PTSD, autism spectrum disorder, etc., and how these infections kind of interface with those conditions, where you can't quite understand what's in the mind of the other person. You can't quite empathize or relate socially. And so that then drives a lot of social disconnection, interpersonal dysfunction, social anxiety, where they can't quite relate or understand. And then it drives even more disconnection from themselves because they feel that they're socially awkward or clumsy, or they're just not able to connect with people very well. So they want to isolate, disconnect even more. And that has a added existential component where they just not really feel that um, that the pleasure and the meaning of these moments are really resonating with them.
As a psychiatrist, obviously you see a very broad scope of different, psychiatric issues. What are your red flags when people are talking with you that, hey, this might be Lyme, it might be a tick-borne illness, because obviously there's so many different symptoms people can experience. What are the things that click off in your brain and go, this just sounds really suspicious? And for people listening, what might be something to say, hey, I need to talk to my psychiatrist or my doctor that I really need to be tested for tick-borne illness?
Oh, that's a really good question. I think that if a person, let's start high level. Let's say if a person's been on a lot of medication, they just can't seem to find a medication that works. Um, I think there's a high likelihood that they have these sort of issues and pathologies in the brain. If they're very sensitive to medications or different agents and things just seem to easily trigger them, I think that's another sign that things may be um, that may be going on. I think if we see a person who has multiple diagnoses, major depressive disorder, post-traumatic stress disorder, autism spectrum disorder, PTSD, and it's like you got every psychiatric diagnosis possible. There's a strong likelihood that one of these toxins and infections are maybe even coupled with a traumatic brain injury are at play. Um, I think that when there are um, issues of awareness that um, the person just have significant social struggles and interpersonal struggles. We might put them into like personality categories and things sometimes. I think that's a strong indication that they too need to look into it. When a person has been in therapy for 5 years, 6 years, 7 years, 8 years, and they still can't quite work through the loss of a loved one or a trauma that they've been through, then that suggests to me that there's something interfering with these brain networks where they can't quite turn over in their brain and work through this issue. It's kind of stuck in a way. Um, I think that's a strong indication as well. Um, I would say that if the person is um, having, you know, persistent, like, let's say trauma or PTSD, they're constantly getting re-traumatized really easily, and it's kind of keep happening. I think that's another indication as well, where they they may have worked through something and then it happens again, that there's a vulnerability there that makes them vulnerable to another insult very easily.
Yeah, I think, in my world, not being a psychiatrist, when I start to hear, though, about this collection of neuropsychiatric symptoms and arthritic symptoms, that makes me very nervous that, I think that there's very few things that cause that combination of both. And that's always an impetus for me to like, hey, let's test you for a tick-borne illness and see if that's part of what's going on. And I wish I could say the 100% it's not, but a lot of times, we do get a hit, with our testing and we find out it's Lyme or Bartonella or Babesia or one of the many infections that's driving that. And of course, having that information is incredibly helpful for you and us, the practitioners. At least we have a roadmap now of how to address that. When you start getting into treatment with your patients, what is a realistic expectation once someone identifies that they have this underlying infection? We suspect this is driving some of the neuropsychiatric symptoms. What's a time frame that people should expect to start to see improvement? And I know it's a very broad question. Everyone's so uniquely different, but is there a reasonable time frame that people can expect to start to see improvement?
So I think there are two time frames, seeing improvement and time. So time to improvement and then time to resolution. Um, I think the people who come in who are um, they did not have these significant issues of childhood. They didn't have like a childhood exposure or infection or congenital, let's say, happened in adulthood. There's a defining moment where they can kind of remember it starting, let's say, anywhere from, definitely if they're less than a year, they have a good chance of recovery really well, up to like 2 or 3 years. They have good stability, support, nice employment, they have resources, they are to some degree intellectually capable of understanding the process, they're responsible. Their personality doesn't lend toward a lot of interpersonal quarrels and fights and power struggles. They're not significantly tilted in a sympathetic sort of significant withdrawal or um, overactivation. And they're not stuck in like fight and flight and things of that nature. I think those people have a really constitutionally strong, I think they have a really, really good chance of recovery and responding really quickly within, a couple of months to up to 6 months. um, I think people on the other end where they've been maybe since childhood, they're not constitutionally strong, they're sensitive, maybe have hormone disruption, they have external dysfunction in their life, don't have much support, they're confused about what's going on, issues of trust and faith. Maybe there are issues with resources. Maybe they are stuck into thinking what's going on with them could be this and maybe could be this. And they bounce around with so many different ideas. Other family members and friends have opinions that are influencing them. They can't quite come to some solid organization. These people are going to have a hard time with treatment. It's going to be a little while before they get improvement. And what improvement looks like for them may not necessarily start out with biological improvement. It may start out with just being able to build a relationship with a provider, building rapport, having some meaningful understanding about what we're doing, how we're going to be thinking about their life and their body, and just kind of getting oriented to the basics of the process. That might be a huge success for that person before we even get to anything biological.
One of the things I know you do in your practice that's a little bit unique, which I actually really like, is you do something called TMS, Transcranial Magnetic Stimulation. Can you tell people a little bit about what that is and why would that potentially be helpful?
I think this is a really important treatment, and this year coming up in ILAS, we're going to have a neuroscience block to talk about this. I think this is an under-tapped area for this community at large. Um, TMS stands for Transcranial Magnetic Stimulation. It's within the treatment category of neuromodulation, and the word neuromodulation means neural, meaning being able to impact the nerves, and modulation, being able to modulate or change the nerve. Um, this is a different concept than perhaps maybe some people are familiar. Many people are familiar with chemical modulation, where we're trying to use a chemical agent to impact nerve function. But here we're using magnetic stimulation. Um, Magnetic stimulation, really took off back in 1985 and got perfected and got its first FDA approved for major depressive disorder in 2008. But it has its origins back into the 1800s, and people have been using magnets for years to treat various things. But now they was able to harness that magnetic energy, and a couple physicists out of the UK and put it into a machine, into a coil that's about 2 Tesla, which is about the same strength of an MRI machine. And we can take that MRI, I mean, we can take that coil, place it over the brain, what I was speaking about earlier, these networks, and we can start to stimulate the brain with a magnetic energy to influence these networks to change. If one network is too active or underactive, we can modulate that and we can bring together a cluster of symptoms all at once. So there are relationships between major depressive disorder, post-traumatic stress disorder, autism spectrum, et cetera, where the same clusters of the brain are involved in those same conditions. So a person can have 2 or 3 or 4 diagnoses that we can all treat with just one treatment. They don't need to be, 5, 6, 7 different medications for that. And so that's one of the beauties of it. Why this matters for this community is because the longer the infections and toxins are there, the more there's going to be network damage in the brain. And simply treating the brain, the body with antibiotics and any other antimicrobial that people are using, whether it be peptides or whatever else, to help the process, is not going to be enough to reboot those neural circuits, get them back to the speed that they need to be at, and to influence coherence and connectivity. And so TMS is such a treatment that can do that. And we can pair TMS with some other things very well, like hyperbaric oxygen to make sure we're flooding the mitochondria with oxygen. Photobiomodulation, we can bring that in as well. Red light therapy with some really nice lasers. And we combine those things together to really start to work on those neuronal tracks to move them in the right direction. I think there are a couple things that people should know about this. We can start this process early before they clear most of the issues, along as long as they're not having significant mast cell activation, cell danger response, too much fight or flight, um, autonomic dysfunction. That needs to be calmed down some before we institute something like TMS. But we can do this very early in treatment and throughout treatment, and then at the end of treatment, where for some people who are confused or they can't cognitively process instructions, or they're having a hard time with thinking about themselves or caring about themselves, or they're having a hard time making decisions, we can impact all that very early on with TMS. And I think it'll make the treatment much easier for the patient and the practitioner, that you don't have to repeat treatment plans two and three and four times, or the person
Right.
emailing you after because I can't remember what you said. What did you say again? And they're kind of disorganized or things of that nature. I think it really helps to recover the brain very early and make treatment a lot easier, while we're waiting on the antimicrobials and other things to take place.
Yeah. Are there any potential downsides? Are there people who are not good candidates for TMS?
Yeah, there are some people who are not good candidates. I think that um, so if there are like metal coils and things in people's head where they have metal clips for different things of that nature, those things are contraindications. You certainly got to think a little bit about if somebody's pregnant. You got to take some precautions if people have a history of bipolar and mania. You got to take precautions if people have seizures. Now, these last two conditions are not automatically excluded, but you want to take that into consideration and you want to lower the intensity of treatment as to not provoke a seizure or mania or something like that. People who are paranoid or significant trauma where they're not yet quite ready to move into safety. They have not yet crossed over into a nice parasympathetic response just yet. They're probably not a good candidate. They might get worse. Their trauma and their agitation, their hypervigilance might get worse with such a treatment. Um, the people who are candidates for it on a non-pathological scale, people who just want to improve brain optimization. Maybe there's a little bit of aging. Maybe you want to, enhance longevity and things of the nature. Maybe you're a business executive and you got a lot of responsibility, a lot of employees. You just want to enlarge your capacity to do the things you do. Maybe you're a mother with three or four kids, a lot of different moving parts. You got a lot of organization you got to keep up with. Perfect candidate to help. It can help neuro psychiatric conditions like autism. We're getting really nice responses, coupling that with the other things we do for autism, um, as young as 3 years old. Um, we can see benefits in PTSD. There's some trials going on right now. Um, Obviously, major depressive disorder, OCD, those are some FDA indications, um, and cognitive impairment at large. Now, the people who doesn't have as much brain pathology, one round of treatment would do them, just well, typically, which is 5 days a week for 6 weeks. But the longer that there's been brain issues, they may need two rounds, up to 60 treatments. And if there's definitely neurodegenerative conditions, dementia, Parkinson's, and things of that nature, they can benefit as well. Sometimes really chronic strokes, they're going to probably need up into 3 rounds of treatment.
Yeah, I mean, I can just speak personally. I have MS, and I did TMS with my neurologist here in Newport Beach. I did 30 sessions, and it helped me tremendously. I mean, it was a significant improvement for me. It was about spasticity, and not really, I think, a well-known indication with TMS anyway. But they targeted parts of my brain that were just associated with my lower limbs, and I noticed that my mobility was much, much better after treatment. And again, it's I'll say relatively non-invasive. A little plate kind of sits over your head, and you feel a little buzzing, which I didn't find terribly uncomfortable. And other than that, just one of these things that generally, like I said, requires several sessions to really get the full benefit. And again, I think out sort of those few FDA approved conditions, I think most people end up paying out of pocket. So it can be a little bit expensive for some folks. But of course, I'm all for any kind of therapy out there that we can do that's relatively non invasive, safe, and gives good clinical results.
Absolutely.
Well, this has been really great. I think helpful for people to understand, how Lyme tick-borne illness can really undermine and hijack your brain at certain times. Before we close, is there anything you'd like to share with the audience?
Yeah, I think one of the things that I've come to learn working with people, I have psychoanalytic training, so I'm listening very intently to the things people say, even though it might sound bizarre or so. And I'm really starting to become convinced that these bugs are old and they carry messages with them throughout history. And when one gets infected with it, because I have a kid with pandas right now, for example, who is having thoughts about old war heroes that he's never read about or known anything about before, right? And it doesn't make sense that he would come to this sort of knowledge just by lived experience.
Yeah.
And so I'm forming some early hypothesis now because I've heard this quite a bit that I think these books carry messages and they infuse their sort of neural circuitry into the brain and upload messages that weird people out,
Yeah.
whether it's sexual thoughts or aggressive thoughts, or whether it be historical knowledge and things that you've never been, you don't have any experiences. And I think that I would like to, continue to build in this. I want to let people know that there is this process that I think is true, that these infections and things can hijack your brain and really make you think that you're talking or you're interacting, but it's not fully you. And I think it's important for people to keep that in mind while they're going through this process. They can't take their thoughts too seriously, and they got to have some degree of index of suspicion, recognizing that these entities think themselves and they are influencing our thinking, or influencing our thinking with their thinking.
Well, that's really helpful information. Do you work with people remotely? Do you only see people in person?
I prefer in person, but yes, some people are remote. Yes.
Okay. Well, for anyone who might be interested in working with Dr. Winfrey, we'll drop his practice information in the show notes. Again, he's just a really great source of information, has a lot of experience in this world. And again, for so many people who've been struggling with these various neuropsychiatric issues, it's nice to have an advocate who really understands, what these tick-borne illnesses can do to your brain. So, Dr. Winfrey, a pleasure having you on the show, and I appreciate you spending time with us today.
Thank you for having me.